Okay, well, good morning, everybody. I'm Paul Boland. I'm Healthcare Director at EBO, and I'd like to welcome you to this morning's webinar. Elective recovery and expanding the use of digital technologies are two of the top 10 priorities for the NHS this year. But of course, with over 6 million patients on elective care waiting lists, NHS Trusts are putting lots and lots of effort into trying to find ways to increase capacity and reduce the backlog. But given the numbers involved, this is obviously a major challenge. So how can artificial intelligence help with elective recovery? And how important is patient engagement in all of this? Well, for the next 40 minutes or so, we're going to explore that very topic. And we'll also be sharing with you how we think EBO could potentially help. I'm going to hand over now to Douglas Hamidishe, who'll be our host for this morning's webinar.
Thank you very much for that warm introduction, Paul. It's a pleasure for me to be here. Thank you for EBO for the invite. Exactly that, Paul. We're here to talk about the transformational solutions that are currently available now, today, to help us tackle the NHS backlog. The waiting lists are through the roof. We know that already. Okay, but throughout this webinar, just want to let the panelists and the viewers out there know that there's a Q&A section. Okay, there's a Q&A box. Okay, so you can fill your questions in, and I'll try my best to get those addressed. And I'll be supported by EBO's senior clinical consultant, Christine Swain, and she'll also try to get back to you in a timely manner. Okay, so please fill your questions if you feel there's something pertinent that you want to ask either myself or one of the panelists directly, okay, but call them out within the message set. So with no further ado, we have Phil Coles, Gary Doherty as well as Paul Boland. So just say hi, guys. Can you have a quick wave?
Hi, morning, everyone.
Hello.
Brilliant stuff, brilliant stuff. So as we're going to get into the meat of the conversation, let's start off by framing it, okay? Now, we know that there are some traditional solutions for tackling the NHS waiting list, typically throw more bodies at it. But when you've got 7 million people on this list, okay, are there any better solutions other than hiring additional staff? So I'm going to put this to Phil. You know, what's your take on that?
Thanks, Douglas. And first of all, I was going to say thanks for inviting me along to this webinar today. It's a delight to be here, to be part of this conversation. It's a great question, Douglas, because we have such long-standing traditional models that try to deliver care in what has been a very unchanging environment for a very long time. And I think, as we all know, the COVID experience has shown us that we can do things differently. We need to engage differently and work with what workforce we have differently. I, prior to COVID, actually went into one of the telephone call centres in the South Wales Health Board, and I was amazed that it was full of people on the telephones with waiting times and everything, and it was absolutely chock-a-block, and clearly it's just not sustainable. We need to be smarter, we need to work with our patients and provide opportunities and choice really about the way they can communicate with the service. And using technology, I think, is definitely one of the options that we have at our disposal, and we need to use all of those different options as part of a toolkit really of solutions to provide that choice for engaging with our patients to understand where they are on waiting lists, how we can support them, and work through solutions like that really. So yes, no, for sure, I don't think we can just employ more people. We haven't got more resource. We haven't got more people to put into more rooms and more telephones. We do need to think differently and smarter about using technology. Now, of course, the telephone is something we all have got. We all know how to use it. So I think there is a place for using the telephone and for supporting patients through that style of communication. But at least with technology and using different innovative solutions, we've got a way to communicate asynchronously. This is the other component that's important. Instead of only operating in office hours, we can actually connect at more convenient times for people and patients and our public at large to be able to converse, support them on their healthcare journey. So lots of opportunities for technology, I think.
No, thank you for that. There's something about making best use of what you currently have, and you did mention the telephone there. And I think there'll be a steady theme here emerging around patient empowerment and this whole choice element, allowing patients to engage with their service on their own terms with a better set of tools. So over to Gary, in terms of what alternative approaches are people exploring locally, and what results are they getting, Gary?
Yeah, thanks. Good morning, everyone. Thanks for the chance to be here this morning. I just kind of briefly build on the previous question slightly before I get into it, and you touched on it, Douglas. I think there's something that, having worked in the NHS 30 odd years, we've always talked a lot about the importance of understanding what our staff want, understanding what our patients want, and in a sense, trying to move away from a sort of interventional remote model of you come for one outpatient appointment, I decide I need to operate on you, you go away again, I then see you, I operate on you. That kind of transactional relationship to a deeper level of understanding. And we've never, to be blunt, kind of really got to that. And I think, this is an opportunity for us to really kind of understand it in a dialogue and an engagement and a co-production situation. What is it that a patient really wants to achieve? Why are they in the system in the first place? And then what is the best way to meet that need in the most efficient way possible and communicate effectively and efficiently? And that, I think, is as I say, a challenge, because that's not easy, but it is a real opportunity. So some of the ways that we're trying to do that in my kind of part of the world, I suspect are not unique, and they're probably similar in lots of other parts. So there's something around how we get the referrals in the first place. There's something around how we maybe give GPs some advice and guidance, some interaction in a digital sense that may be an alternative to the traditional, this patient now must come and actually see you within the hospital. There's then the alternative to actually see the patient online. And certainly anyone who's ever tried to park their car at Preston Hospital, where I work, will know how advantageous that is. And clearly also from a green agenda and a carbon footprint and all sorts of things. There's then that kind of okay, we've had some transactional interactions. How do we maintain a kind of relationship and an understanding of what's going on? How do we understand what's changed, and how do we make sure we pick up on that? So for us, then, we've been using things like kind of digital interaction with patients to get into is their condition deteriorating? Do they still want their operation? Have they already had it? Fortunately, a number of patients, if you like, either go private or have a change in circumstances or don't want the operation. That dialogue then of what's the most convenient time for them to come, how can we schedule them, trying to link that into then the best use of our kind of internal resources. So that's the sort of thing that we've been moving to. I wouldn't say that we're there. In fact, I would say we've taken kind of baby steps. But the results that we've seen, certainly in terms of some of the work we've done with chatbot and other types of interaction, give us kind of at scale, but some personalised communication that's effectively led us then to be able to target. There's no point trying to bring a patient in if they don't want their operation. And there's no point bringing them in if we can't actually do it because we haven't got a bed or a theatre list. So that, I think, is the opportunity that AI and kind of digital gives us.
Sure. And in doing so, I think you alluded to the fact of understanding how clinicians work, understanding the behaviours of patients, which is also important, because as we start to embrace technology, there's an opportunity where we can take a look at tasks that are repetitious and remove those friction points out of the whole interaction between the patient and the service. Okay, so this is a question to both Phil and Gary in terms of this repetition processes that we can actually start to move away from. Where do you see that going? I'll over to Phil first, sorry.
Yeah, for sure. Thanks, Douglas. I think, yeah, it's a really good question, because we often repeat everything we do on a patient-to-patient basis. We phone them up individually. As Gary was saying, just contact people, ask them, do you still want to come to hospital? Do you still want your operation? There are huge opportunities to be able to reach out at scale using smart technology. We've got AI, we've got potential augmented technology, natural language processing opportunities in there. And technology is advancing at such a pace that we need to maximize that opportunity, really, to reach out to patients. And I think part of that journey needs to work with our patients and population, understand how they respond to that. Because I know historically you've had messages and people think, I'm not sure what that message is, do I trust it? And you get all sorts of other strange communications coming out from various chat boxes on websites. So it's important to work with our patients and understand how well that technology can support them at scale, to engage, to understand how we can support the patients on the whole healthcare journey. And also touching back on on Gary's point about our experience in my national clinical lead role, we've discovered that it's really important to work with both the patients and the clinical community using technology. We've really embraced using e-advice across the whole of Wales. We've launched that about 4 or 5 months ago, so that GPs can, instead of referring in automatically, engage in a dialogue with their colleagues to start connecting people, and that communication is absolutely key to ensure that we manage patients most effectively, supporting them appropriately, focusing on maximum value across the whole board, and embracing also prudent-based approaches to delivering care and removing waste from the system. So communication, technology, definitely really important.
Fantastic. And over to you, Gary, just in terms of the rethinking and reframing automation.
Yeah.
It's a language set that's not really synonymous with the NHS. So what sort of work are you doing to reframe that whole automation piece?
So in terms of that kind of dialogue and that kind of clinical conversation with patients, it is very traditional at the moment, generally across the sort of patch and in Lancs and Cumbria where I work, in terms of a constant stream of questions to patients, a kind of fairly archaic means of then capturing the response to that question. And then because either someone can't access the response to that question, or because they think it might have changed for some reason, or because they're a bit worried that they need to be seen to do it again, they ask the same question again and they document it. And whether that's admin staff, whether that's clinical staff, whether it's clerking someone in an ED, and then exactly the same questions get asked on the ward. So there's a multitude of it's not just repetitious, it's identical tasks kind of going on and on again and again. So our kind of challenge, as we sort of try to embrace a kind of digital approach to that, is how can we engage with patients in advance so they can tell us all this stuff? We can then assimilate that information efficiently, not writing it down on a kind of piece of paper while they're in front of us, kind of getting in the way of that kind of relationship building. And then obviously once you've got that sort of digital approach to that, actually seeing what's changed, what's not changed, what someone needs to repeat, you can try to put some intelligence. And where we'd like to get to is where people's precious time, because to pick up Phil's point, you know, as I said, I've worked in the NHS 30 odd years. I can remember when you went out to recruit staff and you got staff. You know, it was a sort of strange, happy time. Now, you know, that equation is just so fundamentally different that in terms of the use of the time of the staff that we've got to carry on not using it well is kind of pretty criminal, really. Plus, you know, clearly by definition, pretty frustrating for the people involved doing pointless tasks again and again. So I think that's the opportunity for us to get that information flow either sought in the first place or captured digitally, and then get some sort of AI or intelligence into it to know what you need to repeat, when you need to repeat it, and not to be doing pointless things.
Absolutely. And I underscore that in terms of skill sets. I was trained to care for patients. Some of the administrative burdens, I was not trained in admin, and I respect anybody proficient in admin. So it's allowing people to do what they were trained to do more effectively, whilst, as you both mentioned there, engage with the patient on better terms. Because there's one thing to be said in having a telephone conversation with a patient, but it's something about introducing a mechanism or using technology to have better engagement that's more based upon a partnership scenario, opposed to, you know, this whole situation where a patient is coming in as a lesser in the situation, where they can contribute a lot more if they just ask the right specific questions. So that will lead me on to talk about the whole patient engagement. I'm going to bring in Paul at this stage. It strikes me that there are a number of aspects of elective recovery that require good regular communication, right, with patients. How important is it to get the patient engagement right? And we touched upon, you know, speaking to them on level terms. You know, I want to hear your take on that. And in order to basically achieve better outcomes, this is all about outcomes here.
Yeah, thanks for that question. I mean, obviously, effective patient engagement is critical to many aspects of care delivery, and I suppose, you know, elective recovery is no different to that. There are obviously elements of elective recovery which absolutely require us to engage at scale with patients. For example, validation of waiting lists, waiting well initiatives, effective booking of short-notice clinic slots, patient-initiated follow-up. There's lots of areas of elective recovery where, you know, interacting with the patient is a key part of it. So they all require good, effective communications at scale in order to work. So I suppose, clearing the backlog does rely on us finding effective methods of communicating with patients en masse to maximize efficiency and create that additional capacity that we really need in the system. I mean, I suppose in an ideal world, we'd pick up the phone to each and every one of those patients and we'd have a proper old-fashioned conversation with them, and that would be our instinct because that's the human thing and that gives us the best opportunity of controlling that conversation. But unfortunately, when the waiting lists are tipping 7 million people, that's probably not viable anymore. And in any event, it's a very expensive, very inefficient way of trying to interact with millions of people. So I suppose what's the alternative, and how do we implement alternatives without losing that human touch? And I suppose, some trusts are obviously using things like SMS and email to communicate with patients, sometimes leading the patient to, filling out a web form on a portal. But I suppose the question is, how effective are those methods of communication? And I think part of the problem is that they're maybe not particularly engaging, and I think the issue there is that they're maybe not interactive enough. They don't maybe make the patient a full participant in the conversation. And I guess the question that I would pose to you is this, would you rather fill out a form or have a conversation? And I think most of us would say, well, actually, I'd rather have a conversation. I just don't want to have to wait on hold for 20 minutes to have it, So I suppose that's what we're talking about here. We're talking about maybe enabling that conversation to happen in an automated way. But we're in a situation where health systems, they just don't have the capacity to cope with demand. So we do need to do everything we can do to encourage patients to use the digital alternative. But I suppose my perspective would be, we have to make that digital alternative better than the other way of doing it, which is picking up the phone. It has to be attractive. Patients have to see that they can get something out of it quicker, get a quicker response, get a better service. So I suppose that's what it's about. It's about making sure that those alternatives we put in place, are as engaging as they possibly can be.
No, thank you very much for that. Thank you very much for that. So over to Phil. How effective do people feel the current methods of patient communications are in the context of things? I know Paul touched upon portals and the traditional telephone waiting type scenario. You can be on there for quite a while. How effective do people feel the current methods of patient communications are in the context of things such as waiting list validation and particularly follow-ups?
Thanks for that question. Yeah, touching on, I suppose, what Paul was saying, I think it's great when you can get on the telephone and you can have a conversation with the right person, and that's also important about who you're talking to. And you can have the time allotted to do that. Often it feels rushed, and you're almost being processed to get through to the next one. So it's around ensuring that those conversations you do have them are effective. They work well when you have them, but as Paul was alluding to, we just haven't got the capacity. You've got patients getting very frustrated, waiting for significant periods of time just to get through on the telephone. And what's the alternative? You've got a letter coming in with a questionnaire you fill out, and it goes out, and you don't know where that goes, what's going to happen next, and you're waiting for an interaction. So I think it's all about trying to make sure that we improve that interaction, that partnership, that ongoing dialogue, and using opportunities to do that as best as we can. So I think, yes, we've got some solutions. We've got SMS, we're reaching out, but we need to try and increase the ability to do that at scale, and that's the key thing, is doing it at scale. And I like what Paul was saying about a conversation. I think if we can have technology that replicates that conversation in a natural way, and the patients and public understand that it does deliver a really good user experience and provides the necessary information back to them in a sort of dialogue conversation, then that can be deployed at incredible scale, and we wouldn't be reliant on ensuring we have all the people manning the telephones all the time.
Oh, great point there, great point. And over to Gary, do you feel that currently we're making full use of digital solution out there, and we're embracing the full capabilities of digital within the NHS?
No, I guess. So I think ultimately what we need to get to is that nothing could or ever should replace the richness of the kind of interaction between people. and obviously some of the staff that we have in the NHS and their amazing kind of knowledge base, combined with then sort of an interaction with a human being, creates the magic. So we can never get away from that. But as I said before, there's a massive amount of pretty basic information and a constantly potentially changing situation that we've got, both a patient in a bed right now, what happens in the next half an hour, versus a patient who's been on a waiting list for 2 years. An awful lot happens there. The question for us is how can we supplement that personal touch with the sort of automated touch, so we can get in enough information in the right efficient way to then be able to apply some magic, if you like, from the AI sort of machine world, where we can spot things before they happen. We can join dots that human beings can't possibly see. We can communicate immediately rather than have kind of delays of hours, weeks, days, months before somebody in part of a system works out that they need to do something because somebody else needs something. And whether that's, and then, really, if we want to get into it, you've got health, social care. We're touching on health a lot this morning. We've got voluntary third sector. We've got other public services. Really joining all that up, getting what we need to really do the job, and then joining it up and using it quickly and efficiently is a massive, a massive opportunity for us. And digital and IT and AI can really help that. Equally, like I say, it doesn't replace the magic, but it takes away a lot of stuff that isn't magic, and it can add its own magic when it can see patterns and raise issues and alerts that human beings just can't see.
No, that's a great point. That's a great point. Now, I like the way you still brought it back to the magic. The real magic will start with the patient to clinician engagement, which we know if you've got 7 million people on the wait list, we don't have the staff. It takes 3 years to train a nurse, 5 years plus for a doctor, and
exactly.
we cannot scale at pace.
Yeah, and as I say, we need both, because let's face it, the times when we all in our own lives really embrace and kind of get into digital is when quite often we have a human side that goes with it. So if we don't get the human magic right in the NHS, people won't engage with, if you like, a digital side of it, because why would they? This is their health we're talking about. We're not talking about ordering the shopping. So if you want to get people working with you, you have to have that. This is not about substitution. It is about kind of complementing. And the two go. And when organisations are good, they generally have both. They have the tech, they have the vision, they have the ambition, but they also have the sort of human touch and the people side absolutely right too. And you put, as I say, you put them two things together, and I think the NHS could really be in a different place, not overnight, but certainly, when you're looking into the sort of 5-10 years, and it will take us 5 years to get really some of this. If you think back to where we were pre-pandemic, we were struggling a bit with waiting lists, but you look back to where we got it to when we were down at 18 weeks. There's a long way to go to get to that point, and we cannot just do it by doing more of the same. And as you said, Douglas, there just aren't the people there. Even if you started training, them today, you just can't do it.
No, great point. And I want to bring back Paul. One of the magic areas I want to talk about is probably one of the hidden benefits of improving the patient interactions with the service, in that you can start to build a wellness model opposed to a sick model, which is what the NHS is currently working on. One of the key drivers there is engagement, and also to be able to have empathy in these digital conversations, because that is what people might miss out or think they're missing out from not having the face-to-face interactions or telephone interactions. How do we get around the empathy using digital solutions?
Yeah, I mean, I suppose all across the system, we're looking at digitalizing patient processes and pathways, because there's a recognition that we can't meet demand if we keep trying to do it the old way. But I suppose there's an inherent risk in doing so, that we're simply reducing that process to its lowest common denominator. So we end up maybe stripping out the human elements and just ending up with, I suppose, the most basic elements of that process, which are typically involves a form of some description, a form-based interaction with the patient, maybe on a website or a mobile app or something like that. And I suppose my sense for it is that is quite a dehumanizing process, and the question that I'd be posing would be, are there ways that we can put that human touch back into the process without maybe necessarily needing armies of staff to do so? And one of the nice things about using conversational AI is that it gives you an opportunity to include things like empathy in the process. So that, for example, if through an automated conversation, a patient says, look, my condition's got much worse, I'm in real pain here, we can actually respond by saying, we're really sorry to hear that. Would you like a clinician to contact you within the next 24 hours? So I suppose there is an opportunity for us to build in that kind of empathy using conversational AI, which is quite exciting.
Brilliant, brilliant stuff. And just to continue on and build on that is, how can AI help in general in terms of just the waiting list and in the broader sense across the health?
Yeah, I mean, so I suppose, maybe what is AI, maybe to start with. So AI is the use of computer science and big data to solve problems that would normally require human intelligence, okay? So a branch of that is conversational AI, or natural language processing, which is focused on language recognition, okay? So there's already examples of us using conversational AI in our day-to-day lives. For example, if you put a search into Google, it will automatically return to you the best matches, the best options. So that's a use of conversational AI. And people might have used the Ask Siri function on your iPhone if you've got one, or maybe an Amazon Alexa around the house. So again, those are examples of conversational AI at use. But I suppose what conversational AI gives health providers is the ability to bring patients into an interactive two-way conversation about their healthcare without needing armies of staff to do it. And it gives patients the opportunity to be active participants in that conversation. So, I mean, ultimately it is about giving patients choice of communication channels and more say in their own healthcare. And using conversational AI, we can design dialogues that really maximize the potential for good patient engagement, because they're totally configurable by specialty or business process. And so we've got a much better chance of influencing the conversation towards a successful outcome for the healthcare provider and the patient. And also we monitor the effectiveness of that conversation using the AI. We've got full audit capabilities. We can spot trends, etc. And that allows us to fine tune the effectiveness of those communications over time. And that's much more effective than using dumb forms of communication like forms and portals, you know? So I suppose the opportunity here is to take that conversational AI and apply it at scale to automated communications to all those millions of people that are on waiting lists.
No, thank you very much for that. At this point, I want to bring Christine into the conversation. Christine, how are you?
I'm good, thank you. Thanks for having me.
No, fantastic, fantastic. Just in the context of what's the evidence like for patients interacting with AI-powered virtual assistants?
Well, at EBO, our patient satisfaction feedback is really good, actually. So patients tell us that they really like using the virtual assistant. Across all clients, our patient feedback satisfaction is about 91%, and the value goes as high as 96%. Particularly where we have full automation in place. So patients actually tell us they want full automation. They want to be able to cancel that appointment without having to speak to a person, because it's quicker and because it's easier for them to do it that way, and they don't have to wait on the line. They told us it's fast and convenient, and actually sometimes they say it's better than a human, because obviously you don't have to wait on the line, you don't have to spend a lot of time doing it. And interestingly, we've seen the same levels of satisfaction in private healthcare, in NHS Trust, in outpatient services like MSK and podiatry, inpatient community mental health. So interestingly, this tells us that obviously the benefits from technology apply across very different patient groups, even those with very specialist needs particularly. But I think what is interesting, obviously, as well, is that even staff really like it. So, you know, the workflows have to obviously work with admin staff and staff managing, clinical staff as well, managing these processes. And what the pilots have shown us is that staff will notice immediately a reduction in calls, which obviously means they can spend more time doing other work. And they all want to continue using the virtual assistant when they're asked at the end of the pilot whether they want to continue.
No, fantastic. Thanks a lot for that. I think there's a common theme emerging, certainly around patient feedback, and that is time across all different specialities. You're giving back their time, which is the most important commodity that you could ever have, particularly when you're suffering from illness. Time is very precious to you, or you're more acutely aware of the time that you have. So any solution that we have that gives back that time needs to be welcomed and embraced. No, so thank you for that, Christine. So we're just going to move on to basically to the panelist responses. Does it sound like AI could have a role in helping with elective recovery in particular? And this is a straight to the panel. So I'm not sure how I want to do it. Let's try and go for Gary first, and then over to Phil, and then if we have Christine and Paul.
So well, I think it is now, I guess, but in probably a kind of patchy, kind of small scale way. So I think that the challenge is how to take what's kind of working now, learn from it, scale it up, and spread it. But also then, I think it's in fairly narrow kind of parts at the moment. And ultimately, what I'd like to see is something that right from the time that a patient feels that they need some help of whatever variety, right then back to the time when that patient is discharged from a kind of rehab or a sort of follow-up outpatient kind of scenario, that all steps along the way of that, there's a communication and an engagement going on with that patient that's digital, that is capturing data and allowing decisions and actions to be taken kind of efficiently and effectively. And as you say, a very good point, with time being by far the most precious commodity to anybody in that. And we still have patients that come into hospital and we can't do their operation because of a variety of reasons, that their condition, that they're not fit, they've done something that doesn't allow us to do that surgery, or they get in and we don't have the right equipment. The equipment we've got isn't in the right condition. We don't have a bed. The anaesthetist is sick. We didn't build in any slack into a system. As I said, bed issues. We didn't have a critical care bed or a HDU bed. So that whole system of scheduling and resource allocation, but then, as you say, particularly that relationship with the person at the end of it, which at the end of the day, if we get through all of that, having deployed all those really expensive resources and the person doesn't get what they want at the end of it, that's pretty poor. But what is it that they want, and how do we find that out in a way that works for them?
Thank you for that. And over to Gary.
Phil.
No, sorry, Phil. Sorry, I do apologize.
That's all right. No, absolutely. Similar to Gary, really. I think the whole system needs to have a refresh, doesn't it? And finding opportunities to do things different and smarter is absolutely key. We can't just keep doing more of the same. We haven't got the resources to do it. So we need to identify within the whole care pathway where we can use technology, particularly artificial intelligence, because that provides maximum enhanced capacity wherever possible. And that comes for, as Gary was saying, organizing our systems, but also engaging with our patients. And I think this is where the discussion here really starts to focus on. And I'm interested actually with some more people commenting in the sidebar around this prioritization. In Wales, we really focused on this. Even during the middle of COVID, we thought at some point down the line, we're going to have a major problem. What are we going to do for this massing number of patients waiting to be seen for a first outpatient as well as for surgery? And of course, we have the Royal College of Surgeons guidance on surgical activity. But the one thing we really recognized is we need information. We need to connect with our patients. And we went down the sending out surveys and questionnaires, but wouldn't it be great if we could do that at scale in a sort of continuous dialogue with our patients, and they have an opportunity to engage themselves instead of being asked? They say, do you know what, I've got a question about my care. Can I reach out somewhere and engage and have a conversation? And that could be through augmented technology in the first instance. And then for those patients where actually a more personal touch, you say that golden nugget of that real personal touch could be then added in when that value is considered to be useful. But at scale, you could really reach out and connect with patients. And when you've done that, you start to gather more and more information about every patient you've got in the system. And then perhaps you have a better way of understanding how to prioritize patients around mitigating or reducing the risk of harm, and prioritizing around the ones with the highest need first. So I think across the whole system, you can see that there's potential opportunities to drop in increased communications through augmented and AI type technologies. In Wales, we're also using AI, of course, in some lead projects for diagnostics. I think this is another part of the pathway where you can increase the speed of turnaround of cases using AI technologies. So AI, I think, is going to be an important part of healthcare and everything we do really into the future, to be honest. And it's really important that people like us on this call today and those attending are part of that AI journey. I think we all need to be engaged and work as a whole system-wide public and community about how we can use AI maximally to support people, the public, our patients, the system, our clinicians as best as we can, safely and efficiently.
No, thank you very much for that. And over to Christine, I just want to go back to the feedback again from patients that you're having using the EBO solution. In recovery, there are 3 words that we use typically. That's hope, opportunity, and control. These are things that the patients want. And certainly from the dialogue that we're having here, I'm seeing that as being the steady theme, plus the additional one of time. Could you just talk a bit more about how important this is for patients?
Well, we can certainly see that it is. One of the key things, obviously, for patients is that they don't want to spend a lot of time waiting on the phone, but actually it's also a matter of getting what they want to get done. So one of the key complaints with NHS Trust is that sometimes patients can't make the appointment slot they've been offered. They want to get in touch with the NHS Trust, but they can't. So they don't cancel, they just don't turn up. And that's obviously with all the staff pressures that there are in the NHS, the last thing you want is patients wasting appointments and DNAing. So that is obviously one way in which they can communicate to the trust without obviously having to go necessarily through a call center. And I think that 2-way conversation is where it really makes a difference. In fact, to be honest, with quite a bit of our clients, we see that adoption, so the number of patients using the virtual assistants tends to increase when the wait on the phone increase, when there's lots more calls. So what tends to happen is there's an overflow and more patients wanting to use the virtual assistant because they just can't get through on the phone line, basically. And I think this is where it really helps, particularly where you have really busy contact centers with a lot of the same calls coming in, where you can manage that large volume patient engagement type interaction and give patients a better service really as well.
No, thank you for that, Christina, because I guess the holy grail of any care service is to be able to provide excellent care in real time, and not having to wait for publications before you understand what best practice is. And something about the AI I'm discovering is this continuous learning loop that you're in. So you can continuously evolve and tweak what's happening, follow the trends in terms of how patients are engaging with your service and act accordingly. So Paul, in terms of this continuous learning piece within EBO, can you talk a bit more about how you can surface information, say, on a dashboard so that a trust can have oversight of what sort of calls are coming in? Christine touched upon that.
Yeah, sure. So, excuse me. So I suppose our expertise in EBO is enabling patient conversations at scale using conversational AI. But I suppose we have developed an end-to-end elective recovery solution that incorporates multi-channel broadcast to patients. That also includes a patient-facing virtual assistant that's AI-powered, that can handle over 100 languages, an admin portal where you can view and manage waiting lists, see them being automatically updated following conversations with patients, control your configuration settings, etc. Full integration capability for EPR and PAS systems, and also the suite of KPI dashboards that you've just referenced, which is about having a kind of a one place where you can monitor all of these communications with waiting patients. So yeah, I suppose it's a comprehensive solution that works end to end. It's available fully integrated with your EPR system or in standalone mode. And I think, you know, the key thing is how it does it. It delivers automation at scale, but it really is about enabling a conversation again, and that's more engaging for patients, and that allows us to build in things like empathy.
No, fantastic, fantastic. And, you know, this conversation has been truly informative and inspirational, because we're talking about things that are available right now to change the whole dynamic. 7 million people on a waiting list, and I'm very conscious of time. So what I want to lead on to is just to the panelists. I'm going to go individually again in terms of your final thoughts. If you can leave people with a final message, what would it be? So I'm going to start off right off the bat with Gary.
Well, I just think, as well, some of the words that you used, I think, you know, there is hope, there is opportunity, there is challenge, though, you know, and as Christine said, you know, we do still have people who just don't turn up to outpatient appointments, which is a pretty strange, you know, if you really stop and think about that, for that to be happening in the current situation that we've got is, you know, is pretty criminal. So I guess there's you know, there is the hope and the opportunity, but then there really is the pressing need to just work differently. And as you say, use what we've got, but use it bigger and better. So I think that would be my closing thoughts.
Thank you very much. And then over to Phil.
So, similar sort of note, I guess. We've just got to start thinking a little bit differently. The NHS was fantastic when it was built and designed in the first place, and unfortunately, it hasn't really moved and progressed at the same pace as the world around us. The needs of our population are changing. The population is growing. We have opportunities and changing technology available. I think we're just way behind the curve. We need to acknowledge that communication is probably the most important part of care, is sharing information, exchanging information, and if we can use alternative ways of doing that, as well as supporting the telephone, so having that choice and multimodal opportunities to engage with patients and using technology to that scale, I think that's where we need to go. The other key message, I suppose, is, as I was mentioning earlier, we are on this journey of embracing technology, and I think we all have to be part of that journey and all work together in a co-produced way with patients and the public to really understand the needs of the population and be responsive to that in an agile way, so that we can really start to deliver the tools and solutions to be able to support patients on their whole healthcare journey.
Oh, thank you, Phil, for that rally call. I was right behind you on that one. So over to Christine. Anything that you'd like to leave the viewers with?
Yes, I think the key is that we want to engage personally with patients, but at scale. So, you know, the average hospital has a waiting list of 40,000. You need to reach out to them regularly. That can tens of thousands of hours if you're going to use staff and a telephone to do that. So I think technology is required so that we can actually scale, do this at scale, and you know, without needing all the extra staff, which to be fair are not out there. We can't really get them, can we, in the NHS? So.
No, great point. And in fact, Christine, to add to that, any trust that's sitting on the fence right now in terms of what capabilities AI can deliver, if you're waiting for staff, you might have to wait another 3 years for them to be trained. This waiting list is just going to get longer and longer and longer. So as you right said, Christine, the staff are not there. So it's something about making best use of what you have, and we have mechanisms for communication. What we're doing now is introducing better mechanisms to improve that communication channel. Over to Paul to just bring it on.
Yeah, I mean, I suppose I just close by saying, you know, we need to do things differently. We need to introduce automation and the opportunities that automation brings to the elective recovery solution. And I think we have to acknowledge that engaging patients more effectively is a massive part of that. And I suppose I'd say it again, you know, do you think that people would prefer to fill out a form or have a conversation? I think instinctively we know they'd rather have a conversation. So is there an opportunity here for us to facilitate an automated conversation that brings patients into the process in a better way to result in better outcomes for everybody? And I think there probably is. And if you agree, then it might be worth exploring this in a little bit more detail with us.
Fantastic. And I just want to say thank you to all the panelists. You were excellent. You shared some very useful insights, and I'm sure you're available, and you just nod to agree that your email so that people can contact you directly of any questions, particularly around elective recovery solutions. If you want to contact EBO, sorry, I think I was going too far there. If you want to have any questions specifically to EBO, they're willing and able to receive any questions regarding the elective recovery solution. You can book a free one-to-one consultation with the EBO team. But again, the panelists have been answering questions in the chat, so please reach out and we can connect you. And I just want to say thank you guys for attending and listening to the conversation, and we'll catch you on the next series. Thank you very much.